calling for a rather holistic intervention. As well as that, there is a direct continuity of ADHD into adult life. And that's been emphasized recently in the last few weeks by studies of never-treated adults free of stimulant medication, who in one study from the Brookhaven National Laboratory turn out to have rather low levels of dopamine and dopamine transporter in the striatum. And from my own group at the Institute of Psychiatry, and again, never-treated adults who show quite marked persistence of the hypoactivation of striatal and frontal structures in functional magnetic resonance imaging and alterations of connectivity. So there is a direct biological continuity of problem as well as a transactional influence. Peter Timms and Christine Merrill have recently reported a large trial with randomized allocation, 2 different forms of classroom intervention. One intervention was a screening program in which the children entering year 1, age about 6, are rated by their teachers. These are centrally marked, but with the return of the information. The information is fed back about whether the child meets criteria for ADHD, so that in theory special intervention can be taken. The effect size was 0. Another intervention was an education process for the head teachers and the coordinators of special education in the schools. The effect of that, the effect size was 0. An intervention that did have an effect was quite a cheap one, for a booklet costing £2, costing about €3, is sent to all the teachers in the cooperating schools. It contains key facts, such as I've just given you, about the nature of ADHD and the tips for dealing with it. The effect size of that was 0.26. This is a small effect size, but a real one. The size is large, so the confidence limits are narrow. It's a very cost-effective intervention, and it illustrates the importance of what happens moment to moment in the school, rather than what happens overall in the broad aspects of school organization. So, in thinking about drugs or behavior therapy, we can say that both are effective, both are cost-effective. There are hazards with medication: growth suppression, which is usually manageable in clinical practice, hypertension, similarly avoidable, and an unknown level of cardiovascular risk, possibly as high as sudden death, but with a highly controversial lack of information about that and an uncertainty about whether it is in fact any greater than in the population as a whole. The overall conclusions at the 14-month point were that medication is more powerful than behavioral treatment. Research treatment is better than routine, and that there are many advantages to adding medication to behavior, but few in adding behavior to medication. This was a very influential finding, I think perhaps especially in some European countries, and led to a marked expansion of the use of medication. Given that I think that the economic modelling suggests that the relative effect of medication to behavior is so much greater in the hyperkinetic subtype that it justifies the following kind of algorithm. If it's severe, pervasive, and disabling, in effect in the hyperkinetic category, then you go straight to medication and follow up with behavior therapy if that's not sufficient. If it's not like that, then problems at home lead to behavior therapy at home, problems at school to classroom management, and it's only if it's persistent after that that you go on to medication. This line of going directly from reported problems to medication wasn't advocated by NICE or by the European guidelines, except in those cases where it comes into that severe group. So the key recommendations from NICE are here, but I would take the answer to the question we started with about drugs or no drugs, take that the answer is yes. Both are needed. Thank you.